Good afternoon. I'm going to go ahead and get started. As will become normal, before every session, you'll hear the same housekeeping, PSA. So I'm just going to go ahead and start. Good afternoon and welcome to How to Be an Integrated Partner in a Value-Based Market, jointly presented by the Alliance for Home Healthcare and Innovation and the Visiting Nurses Association of America. This session is being recorded. This continuing nurse education activity has been approved for 1 contact hour by the Maryland Nurses Association, an accredited approver by the American Nurses Credentialing Center's Commission on Accreditation. In order to receive your certificate of completion, you'll need to attend this program in its entirety, complete the evaluation, which is available in your conference app. Certificates of completion are available at the registration desk. I just wanted to make a note that you'll get 1 certificate for all of the contact hours you complete, and you can pick that up at the end of the conference or when you're done. Our faculty has disclosed no financial conflict of interest, and a copy of the full disclosure sheet is available on the table outside the room. So with that, I'm going to go ahead and introduce our speakers. Are you guys sitting in the order you're presenting? I just wanted to then introduce in that order. Margarita Lapson is the Executive Director for the Home Care Program at the Joint Commission. In this role, she's responsible for coordinating the efforts of Home Care Business Development Team in identifying new markets, familiarizing organizations with the accreditation process, participating in new product development, and the strategic development and tactical operations of the Home Care Accreditation Program. Also joining her is Marki Flannery, who is a 32-year career veteran she's been at Visiting Nurse of New York since 1982 and began a 32-year career at Partners in Care, an affiliate of the VNSMY, and its inception in 1983. Marki returned to VNSMY in January 2015 in the role of Executive Vice President and Chief of Provider Operations. In her current role, Marki is responsible for the Certified Home Health Agency, Hospice and Palliative Care Services, the Licensed Home Care Services Agency, all community mental health and children family grant programs, home health services, sales, marketing, and communications, volunteer services, strategy, quality, and support services. So clearly, we're lucky that we're lucky you have the time, man. Also joining us is Scott Vassy, who serves as the Senior Vice President of Strategy for VNSNY. Scott is responsible for corporate strategy under value-based care models of care and payment, managed care contracting, consumer partner solution development, performance innovation, and government program strategy, including grants, New York DSRIP PPS programs, and CMS bundled payments. Thank you all for joining us. I appreciate it greatly. And with that, I'm going to turn it over to you all. Thank you.
And that concludes our hour. Thank you for coming. No, sorry. Okay, so we're going to move past this, and these are the objectives for today's presentation. So really, when we came together, our intention is to really help you explore the forces driving integration, and then go more granular with that, starting to look at the different domains of an integrated system, and more importantly, the critical to quality demands of these different domains. And finally, to inspire you to begin considering your own organizations, your own journey towards integration. Ultimately, our goal is to help you continue what was so thoughtfully begun this morning, to heighten our collective awareness that we've always been a part of the care continuum, and agree to elevate home in the minds of providers and the public, because we've always been at the center of where healthcare is being delivered. If you define the center as where most healthcare is being delivered and where healthcare is best delivered and most safely delivered. When we look at the industry landscapes in particular, I wanted to just really briefly do an environmental scan of the healthcare, because this is a unique period in time. Very rarely in the course of recorded history have we had such shifts in population where we're really not replacing our existing populations with a commensurate amount of individuals. That is to say, we have the elderly growing older faster in larger and larger populations. We don't have replacement necessarily coming up behind them in a fashion that they're willing to assume the roles that are being left by the aging population. There's also an incredibly shifting need, and so frankly, when we talk in front of our audiences, when we start to think about where care has been and is going, we start to look at the fact that care to this moment in time has really been episodic and transactional. You get a patient home from an acute care facility, you take care of that particular patient, that episode goes away, you move on. But the fact of the matter is, as a result of advancements in both pharma and in medical sciences, we are now dealing with the management of these chronic comorbidities and palliative care. So when you think out towards the future of our work, think that there's a very high likelihood that in the next 15 years, chronic care management, palliative care management, and the management of serious diseases will become the mainstay of our history, just as specialty pharmacies will become the mainstay of the pharmacy industry. There are some unique generational expectations too, in terms of the millennials, and I know there's always this push-pull between the millennials and the Gen Xers and the boomers. Very frequently now, the boomers that typically hold the senior positions in many organizations are like, you can't get them to stay. They have a completely different set of rules, where boomers are do or die for apple pie, and that's not the way. I will tell you, a colleague said to me the other day that the millennials actually have a third parent. That third parent is the worldwide internet. And so that is their place where they go for information, and it does color their world. Things like, not living to work, but working to live are far more important to them. And certainly the one thing that they really don't understand is they don't understand doing things inefficiently, because they are able to secure that information rather quickly and from a variety of sources. I also want to share with you one other thing when we're thinking about the millennials, and that is the millennials are the first generation that are born and completely educated in an educational system that emphasizes team over individual competition. And that's unique, because if you're a boomer like me, and I'm not going to necessarily disclose how much of a boomer I am, but if you're a boomer like me, we were taught to compete individual against individual. And now in a world where we are facing the need to integrate care and to partner and participate, that hurts us. But as these generations come up behind us, the Gen Xers and even more so the millennials, this will begin to smooth its way out. Also, the fact that these medical advancements and these pharma advancements, two sides of the same coin, they say, are really going to help shift the populations that we're going to be asked to care for. Now, when you contrast this against our industry landscape, you figure out that not much rocket science here. Our regulatory, our regulations move at a glacial pace and incrementally, a little to the left or a little to the right. All bets are off, and I'm not making any political statements about today's market, but historically, it's never really moved very much one way or the other, and it's just moved at an incredibly slow pace compared to the pace of our practice evolving. In terms of reimbursement, the one good thing about reimbursement that I will sign on to is that it does uncomfortably force us to revisit and think about better ways of doing things. The unfortunate thing is that we are not really used to partnering. It's been a highly competitive landscape, and the success of integration is built on a high level of trust between organizations that you'll work collaboratively with one another without necessarily committing political suicide. In terms of patient and provider relationships, the whole concept of a patient and a provider relationship requires a cultural mindset for the healthcare industry. And the speakers this morning, if you were in the plenary sessions, alluded to this to some extent, where there was a reluctance to allow certain types of testing or equipment or services to be provided in the home because we were worried that the patient wouldn't do it, wouldn't take it on. And the fact of the matter is it really, in order for us to have success with an integrated delivery system, you are dependent upon that patient or that healthcare consumer being fully engaged and a participant in the process. And absent that, you're going to be forever chasing yourselves down the corridor, trying to catch up and measure and monitor. It's not going to work. So the whole concepts, where I work, we track what's called Sentinel events. It's a voluntary reporting system. And when you do the root cause analysis, historically, going all the way back to the beginning of when we ever charted Sentinel events, the same three key root cause and the same three key systems come up to bat as the first, second, or third reason why it occurs. It's either a leadership failure, communication system failure, or a human factors failure, and these things keep cycling around. You cannot have success in an integrated care delivery system absent the engagement of a healthcare consumer with whom you're doing business. The other thing is, and where I said it really gets into the cultural mindset, is that requires the provider to change their mindset. And in many instances, and think about this, you may have a supervisor, you may have a physician you're working with, you may have a nurse practitioner. And that nurse and that supervisor says, these nurse practitioners, I got more education than they have. I can tell them how to do their job better. Or a PA. The world is evolving around them, but they keep these cultural mindsets that's going to color the way that they interact inside these integrated delivery care systems, and you're going to have to work as leaders to vet that out in order for you to move forward, because you're going to need a good, you're going to at least need to be in a good stream of consciousness. To say we have a complex and uncoordinated system, I'm sure is an understatement. In many parts of the country, it's rather clunky. But the one thing that I do want you to know is that it is going to ultimately smooth out. It's just that it's kind of banging together right now, simply because the forces are lining up much faster than the capabilities. So here's where we end up with the recognition that the outcomes, and this is an important thing because this is frequently misrepresented, poor outcomes are not necessarily caused by people that don't care or want to do the wrong thing. Poor outcomes are most often, if you drill down, caused by people that are overlooking the process and assuming it's going to get caught downstream. One of the examples that I can think right off the top of my head, and all of us where I work, we still need to practice in our respective areas of expertise. So I practice in the area of case management. So we had a clinician, she needed to send the patient back to the hospital. It wasn't anything we could manage from a palliative care standpoint in the home. We needed to send him back, and we were doing the checklist before we sent him back. And I said, I don't see that piece of that information. She goes, oh, they'll know at the hospital. And I said, no, stop. And I have the right as a certified, any member of our team has the right to go, no, stop. And they have to stop, and we have to fill out that information. Because the reality of it is, that's where your poor outcomes occur. People just go over it. It doesn't come up on their collective consciousness. In fact, one of the characteristics of a high reliability organization is that they demonstrate the ability to eschew those kinds of assumptions, and they will dig to find the correct answer and make sure something is complete. The other thing that we've noticed as we've worked with integrated care delivery systems and studied the data underneath it and the analytics underneath it is the administrative processes are often as broken as the clinical processes. And that's a huge eye-opener for the leadership, because most times when they're thinking outcomes, what do they think? They jump immediately over their administrative processes and they look squarely at the clinical processes. And they're missing the aspects that those administrative processes insufficiently support the clinical processes. So other things to consider. Finally, the third bullet I can't stress enough to you. Quality improvement projects don't always save money. If I throw enough money at anything, I can change a whole system and make it look absolutely pristine. But a project in and of itself is like a diet, folks. They start and they end. And then usually everything goes back to the way it was. I am living proof. I have more years than I can get. There's done a diet I haven't been on. So stop thinking of these things as quality improvement projects and start thinking of them as a journey that's embedding the ability for you to measure and monitor your own performance. It's very difficult for you to sustain or spread anything if you start to think of things as a quality improvement projects. The most important thing that you can do is to begin to really do a data-driven analysis of your capability. One of the interesting pieces that we found was that it's human nature to some extent that organizations, especially less than well-informed leaders, will overestimate the capabilities and underestimate the risk involved with integration and bundles and different types of alternate payment models. They'll overestimate the capabilities of their staff to sustain that, and they'll underestimate the risk involved. So just transitioning from fee-for-service to this value-based payment has created this whole new lexicon of multiple meanings, okay? So integrated care. We were on the phone the other day, and at my house, or where I work, we represent all different programs from across the continuum, and it's not a linear continuum. It's really a big ball, and it just depends on where that patient needs to be at that particular moment in time. And we were sitting on the phone, and we were talking with a payer that was exploring some recognition, and I'm hearing integration. And so I finally got the floor, and I said, talk to me a little bit about how you see the integration of the services in the community. I'm talking about home health and hospice services, private duty if necessary, diagnostic services, transport services, specialty pharmacy. We're only talking about the physicians integrating with the hospital. I said, they don't do that already? And the fact of the matter is, I knew the answer already. To many of us, to many of our providers that are freestanding and that aren't really affiliated, they think that the hospitals and the physicians are well integrated, and they're not. There's different needs there. But I think what's even more important is that they think that that's integrated care. They really believe that that's an integrated delivery system, and there's so much that they're missing. There's so much that they're missing. I reminded them that most often the one healthcare provider that a patient will see most in their lifetime is the pharmacist when they pick up their prescriptions. That's what the data tells us. And I'm not that I'll live and die by all data, but at least begin to raise the awareness around here. Managing to a variety of new payers. Rose spoke to this morning. I was so proud of you when you got up and said that, because I have been in that seat where you have 3 different payers on this side, and then you have CMS on that side. They all want a metric called readmission rate. They all want that measured, and they all measure it differently. What ends up happening is you have measure fatigue, and just like you get project fatigue if you assume quality improvement projects. So it is important that if you go into an integrated system that you do have those kinds of dashboards. The impact on your organizational strategy, the one thing I will tell you is just if you can embed in your processes, which you really need to do, because your leadership at the end of the day is going to use that to drive it forward. And then again, it will help you focus. We do know that transitioning is going to help us focus on operational efficiencies. It can't do anything more than that unless you're going, otherwise you're moving deck chairs around the Titanic. So at the end of the day, what we have is the 7 domains. And I pulled this not from a home care specific piece of information. I pulled this from a healthcare specific piece. There are 7 domains of a fully integrated system. There are very few fully integrated systems. And I will tell you the linchpin of all of this is that first button, a value-driven governance and leaders. If your leaders are not on board, if they are not fully committed, accountable, and engaged, you have little likelihood of success with your integrated delivery system. It's going to be difficult. It's going to be an uphill push the whole way. The other, here you can see the hospital and physician alignment. That's at a minimum. but certainly there are, in most instances, it's been my experience in working with the providers I'm privileged to work with, that we've had to help those providers get in front of the health systems and the physician groups to help them explain how they can really optimize and leverage the existence of a home health or a hospice to improve their outcomes. Financial integration. What we have noticed in looking at these domains is that every participant or provider participant within this integrated system has to be capable of measuring both their financial risk and their capabilities there, and they really do need to understand what they're measuring. And so many times what we find when working with the home health or the hospice providers is they're not really prepared to understand that, so that may take some development on the part of your staff. Information continuity, I don't know how many times I think I'm going to just have it on my tombstone. Home care was never given money for the electronic health record, and we are not given access to it. And it remains the bane of our existence. Just keep on pushing, keep on pushing. Even with the major IT systems, they are working on it, but there's no perfect outcome yet. In terms of patient-centered and population-focused, there is a human aspect to this component that is important that you examine, and I'll use the example of pain management. If part of your integrated care delivery system includes the management of a special population that includes those patients with chronic pain management, it's important that that everyone holds the same belief system with respect to those particular patients, because if we accept the fact that I'll just use this as an example. We accept as a tenet of our integrated delivery system in this population that we are managing, that what the patient's reported pain level is, we accept that as truth. And you are going to find, please tell me if you don't, because I really do want to meet the first organization that didn't find this. But you're going to find that within the scope of your providers inside that group and the families and the patients and caregivers that you're taking care of, that not everybody's going to sign on to that. And people always say, well, God, Marguerite, I don't understand why that is. And I said, I have 5 kids. They're as integrated as they get. And they don't even hold the same beliefs. I got to constantly say, we don't do that. Or, yes, this is the way we deal with things. So it's important to realize that as you develop these integrated care systems, just because you write it in a policy, develop it in a procedure, you've got to look at how that human experience and the experiential history of that clinician is living its way out. And then, of course, commit to sustained quality improvement and innovation. And it really becomes the way that you measure your work. And I will just say this much insofar as that's concerned, and that is that as you report this out publicly, that begins to drive your own performance. So if you're struggling with getting sustained performance, start reporting it out in a very visible way inside your organization, and it's amazing. The staff will pick up on that and begin to drive their own performance. Nobody wants to be in last place there. Nobody wants to be, showing the one with difficulty, and they will begin to search each other out for best practices. In preparation for this, I went to the groups that we currently work with to talk and asked them, tell me about what you've noticed are the benefits of your integration. And this is what they shared with me, and I thought I would share those with you. Please notice that there are 3 domains there. There's three different areas there, and that is to remind you that please try to measure each of those so that you get a 360 view of how you'll move forward in your integrative delivery system. When talking about where to begin and how to move forward, you cannot invest enough time and effort in the development of your leadership. And I'm not talking about traditional leadership, I'm talking about transformational leadership that really looks at beginning to embed a process and then have a clear vision and then exhibit a level of engagement and commitment so that they are completely resilient to what's coming down the pike and they have unwavering support for it. You need, one of the things that is one of the one of the critical to quality efforts that we found is when you have officers who serve as champions of components of integrated delivery systems, that makes a huge difference in the ability of those systems to go forward and to be successful and to sustain their success. But you need someone at the highest level to really help move that forward. Transformational leadership, there's a ton of literature out there, and certainly if not, check our website. There's a lot of free stuff on there. Help yourselves to it. That transformational leadership is a different way of leading. It's a different mindset, and it takes time to develop, and we're all on that journey. We just all are on that journey. And then resilient and accountable. In terms of where to focus, I went again to our provider partners and I said, okay, so I'm going to be talking with a few of our colleagues. What should I tell them? And it comes back to where we know that the highest risks are. Program alignment, where the nexus is of the movement between one to another. Just like we say, where does communication get messed up? It's at the point that it happens. The transmitter doesn't transmit in a fashion that the receiver can receive. Same thing with the program alignment. Make sure that you and I both understand that this is my responsibility to you, this is what you'll accept from me, and vice versa. The program characteristics, make sure that they line up. And I'll show you, one of the lessons learned was when we have an integrated care certified system right now. And one of the things that they identified as the first thing that came up insofar as the program characteristics was where there were gaps. So your program characteristics, take time to look at those key characteristics. The components of how you'll manage pain, the components of your administrative work, certainly your contracting expectations and your financial risk. And then quality, safety, and culture. You will find as you move into these integrated care delivery systems that it is almost the culture, your cultural mindset of the staff that you engage and the partners that you employ becomes more important than just their demographic representation. Some additional key components to consider. These are the processes that we recommend that you very robustly evaluate, and certainly there's a lot of tools out there, and I'm happy to talk with any one of you. I want to make sure that both Marki and Steve have time. But your clinical integration, that's where things like how you will manage pain, your algorithms for treatment, how physicians will be notified, the use of the licensed independent practitioners, or I think the moniker now is the physician extenders. Certainly patient-centeredness, because we have a ways to go with patient-centeredness. What we see now, the majority of the time, is sort of parallel play. I do my thing, you do your thing, and we kind of have a few touch points in between. Integrated care delivery systems are much more involved, much more of a journey, and require a substantially higher level of trust than you will see in most organizations, and certainly requires competitors to begin to align with one another as well. So this is, I went to actually the first one of our organizations to hold this, and I said, talk to me about what I should tell folks. And these were their messages. When they started to really do the alignment, they were able to clearly see what care wasn't being delivered. They were kind of shocked that it came alive to them. They were able to effectively work to close the gaps, but it did require a level of real trust. Their leadership owns and continues to own the process and remains a champion. The other thing is that you have to be sure, this is a mandate, you've got to be sure that everybody going into that system from a staff perspective and even from a healthcare consumer's perspective understands that this is integration. Because otherwise what ends up happening is you're going to start running into, well, Dr. So-and-so said I didn't have to do this. Well, the home care doctor said I did have to do this. Well, we're not going to measure that today. Why aren't we going to measure that today? Well, because Dr. So-and-so, we didn't have to. No, there's an agreement here. This is what gets measured. This is what gets reported. And then if you have, make sure that you have physician champions and you continue to nurture those physician champions. With that, I am going to turn it over to Marki. Thanks.
So good afternoon, everyone. So we've just heard from Margarita about the importance of being an integrated partner. And as we see the healthcare industry becoming more and more focused on value, we need to determine how we can make sure that we're a partner with these hospitals, health systems, and health plans. So we have to start by figuring out and understanding what value means to them. Clearly, they're concerned about keeping patients out of the hospital. That's an easy one. They are absolutely focused on reducing rehospitalization rates, and if a patient comes to our care and winds up back in the hospital, that is something that they're really concerned about. They're concerned about the cost of care, so they'd like us to help them bring the cost of care down. And they hear about the patient experience. They're rated from a patient experience perspective, just like we are, and they want to make sure that we are delivering the best possible experience so that they are rated appropriately as well. So as we are looking at different relationships, whether they are relationships in bundle payment, or at-risk relationships with accountable care organizations, every one of them has these same value focus areas that they would like support in an effort to reduce their costs, their hospital readmissions, and they're improving the patient experience. So one of the key facts that we show there, in 2015, hospitals who were in orthopedic bundles had savings of $3,724 per case. Our home care utilization in those cases actually increased. And we know that that increased by 21%. So they're looking at our cost as much as they're looking at their savings. So while our cost is helping perhaps to reduce overall cost of care, they still are questioning if our cost goes up. So we need to manage our cost of care as well as improving the outcomes associated with that. So where do we fit into this? So we are clearly part of a post-acute setting. Home health care is part of that, and we want to make sure that we're seen as a partner in that regard. So as we align with the value-based market, we have to show what we can do for them and prove the value of our home health care experience. So there are things that we do that we know that the hospital and physician market doesn't necessarily do once a patient gets discharged. We call, we monitor, we visit, we act on what we learn in the home, what we see the patient's experience is. In our organization, we've developed a care management department, and we focus on making sure that our population health team is managing the care of our patients once they are no longer receiving services from home health or certified home health agency services. So an example of that is we have a patient with congestive heart failure, and we'll make sure that there are scales in the home for the patient to be able to weigh themselves so that we know if there is a change in condition that could potentially result in a rehospitalization. Just a couple of weeks ago, contrary to beautiful weather we have outside here, we had a significant snowstorm in New York. And it came upon really quickly that we learned we were going to have this snowstorm. And our population health team reached out to every single patient that we have that we're care managing to make sure that they had meds in the home, that they had adequate food, because the risk is that if they were without any kind of support over a couple of day period and they didn't have their meds, they would have wound up back in the hospital. And in fact, we found that there were a couple of patients, not too many, who didn't have medications, and we made arrangements with the local pharmacy to get those meds delivered to the home. And if we needed to, we would have sent an aide to go pick them up and bring them to the home, because that's a lot less expensive than having a rehospitalization. So we do things that others don't think about in an effort to make sure that we are keeping our patients home. That's the value of home health, and that's part of what we need to prove to other organizations in terms of our value. So just moving on, I'm trying to move fast so Scott gets some time. So home care within an integrated delivery system. So we have significant relationships with hospitals, physician practices, and what we're hearing is that many of them are struggling with reducing rehospitalization rates. Patients discharged and then the patient gets rehospitalized. And these are not necessarily patients who go into home health. They may not be getting home care services. And so many of them are developing their own care management structures within the hospital setting, for example, but this is not their area of expertise. So they're developing these high-cost models, which are not really effective. They don't have the types of relationships with the community to be able to arrange for support in the community, and they're not focused on meeting the needs in the home care environment. So they're not as effective as they could be, and duplicating in many ways what we're already doing in the home health world. So it's our job to help them understand what are the things that we can bring to them so that they stop trying to duplicate and perhaps do a better job of partnering with the home health care environment. So some of the things that we do in home health is we do medication reconciliation. We know that that's a standard role in the home health environment. Another thing that we do, and it's important to do, is to identify various social determinants. And so those are things like looking at the home environment. We do a caregiver strain index. We look at their ability to afford meds. So not every patient can afford the meds that are given to them, and then they don't take them. And that results in rehospitalizations. We make sure that they have access to transportation. So if they're supposed to get to their primary care physician after discharge, but they don't have access to transportation, or it's not easy access, they're not going to go. And we know those are reasons for rehospitalization. So we help make arrangements. Some of them don't have food in the home, and they don't have access to food in the home. So by managing that and supporting them in that way, we're able to have positive outcomes in terms of reductions in rehospitalization rates, and clearly, as a result, reductions in cost. So we have the care management team that does the things that I'm describing, and one of the things that Scott will share with you as well is that we find that the results are very effective. And in his discussions with the health plans that we contract with, and many of these are Medicaid health plans within managed care plans within the New York market, is he'll ask them what their experience is in terms of their reach. You know, their care managing within their organizations, what is their level of reach? And it's probably somewhere near 10 to 20%. And they think they're doing a good job. And our reach is probably closer to 90 to 100%. So there is a benefit to working with the home health environment. Not only are we reaching them when they're part of the home care experience, but we're continuing to manage them after the home care experience ends, because we're in a number of value-based relationships where we're responsible to deliver care for an extended period of time. We also have the benefit of the OASIS data, which is really much more rich and valuable data than what they even have within the hospital record. So we're able to look at what's in the OASIS data to guide us in terms of what it is that we need to do to improve the care for that patient at the point of discharge and in the home, so that they again minimize the risk of rehospitalization. And then additionally, we have a team of individuals who serve patients, whether they're serving them during the home care experience or once we have care management, we have access to support. So it's a multidisciplinary approach. Our usual and customary are nursing, therapy, social work, home health aid services, but we also offer within the home health environment, we have hospice and palliative care. In a number of markets, there are health homes, there's behavioral health services, there are physicians and nurse practitioners on call. We've engaged with one of our hospital partners for a community paramedicine program whereby patients who would have called 911 are given the opportunity to have a community paramedicine service brought to the home to provide assistance and prior to making the decision to go to the emergency room. And so we're working with one of our hospital partners to pilot that in an effort to reduce the return to the hospital and potential readmission. And then we use patient escorts, we use health coaches, we use telemedicine, we use remote patient monitoring, and then we have pharmacy that also can support evaluating whether or not there are changes that need to be done in the home in terms of supporting the meds. So, our job is to show the solution partner that they need us and that we can show them that by providing the data that we have. Our results this year, we started in a number of value arrangements with a couple of insurance plans, and we found that since the beginning of this year, in the first 60 days, we were able to reduce our rehospitalizations by 10%. And for those that we're monitoring for 90%, for 90 days, we were able to reduce by 20%. So we know that this kind of effort that we have within the home health environment is able to deliver on results. So with that, I will turn it over to Scott, who will continue.
Okay, thank you. I think the challenge that we face as a business community is that value for us is now a cultural shift. It's not just about educating patients around new methodologies of patient engagement and treatment, but it's also around educating our employees and the industry around the culture of value. That the culture of value begins in 5 different domains: through executive leadership, through clinical leadership, operational leadership, obviously within the IT and analytics domain, as well as the financial leadership. In order to do that, we have to understand that as agencies, we have to educate our staff and our patients about the shift to value and what value means. And that it's not just the decreasing total cost of care, it's also about improving quality and patient experience along the way. When I began a couple years ago working across the country with different risk-based agencies, there wasn't people inside of those organizations that were taking on risk that could spell ACO or VBP or BPCI or fee-for-service or FSS. These were things that were foreign concepts to them, and yet they were asked to enable their organizations to participate in those types of arrangements. And until you can actually explain to them what it is in it for them, they're not really grasping the concept that this is important, the way that we manage and care for patients and change the culture in which we live. When we do that, we align our partnerships so that everybody participating understands that we're in this together, and those partnerships may have previously been competitors in our own space, or misaligned providers who actually didn't participate or I should say they participated in silos. We do have to be creative in our arrangements and making sure that as we're sharing risk or shifting risk, that we do remain compliant with other regulatory statutes, and that it is based in effective communications with the providers and the patients. The clinical pathways then actually have to be shared and aligned, right? And we, again, living in silos, we may develop clinical pathways within the inpatient unit, within the subacute, within the home care environment, within the primary care environment, within the ACO environment wrapped around the primary care. But if we're not sharing clinical pathways and looking at the patient as a continuum of care and shifting that care from institutions of illness to a community of care and looking at the care community as a continuum, then we're actually not doing anything more or beneficial or anything different for the patient themselves. So sharing those care pathways and aligning those care pathways around those disease cohorts is only going to enable us to be able to do our own work better. Typically, we've been pretty proprietary about that, right? We've protected our information in our care pathways, and only through sharing will that actually occur. As Marki said, it has to be a multidisciplinary approach. So it's not, and I think one of the other folks this morning was talking about it, it's really not just centered around the PCP, right? It's centered around the patient, and then we wrap the service disciplines around them, and we have to start acting in a multidisciplinary approach. And then obviously focusing on that patient experience, ensuring that the patient can actually handle it. Because this is a lot of information, and this is a lot of care being wrapped around them. One of the things that we've engaged with our hospital association in the state of New York is around the layers of care management now that could be potentially touching this patient. And it sort of creates this numbness, right? When they have a discharge planner calling them at post-discharge, and then they have a care manager that's calling from the health plan, a care manager that's calling from the home health organization, a care manager that's calling them from the ACO or the primary care, a care manager that's calling from the health home, or other activities that are going on. They become numb to the experience, and you really have to focus in on who owns the patient at the time of the patient experience that they're experiencing in the moment, whether it's in acute care or in a post-acute setting, or whether it's in the community, and ensure that they're actually actively engaged in that treatment protocol. Moved. One of the things I think that we often overlook, however, in the value-based model is how essential operations is. And one of the examples I usually give is that in a functional ACO in Texas, they set up a rewards program that anybody who engaged in a patient engagement activity that would have otherwise improved their STAR scores, as we talked a little bit about this morning as well, would be rewarded. And one of the things I thought was pretty interesting about their experience is that they found that the intake nurse into the physician's offices was often the most active participant in that, and could identify gaps in care better than physicians could, or better than any care management algorithm could. They would identify that a patient coming to the hospital with their spouse who hadn't been seen in a year, they could engage then that spouse in saying, Mr. Smith, you haven't been seen in a year, why don't you come in and be seen? And they remediated 4 gaps in care. And those types of operational engagement strategies with our, if you have a 24-hour call center or just an intake staff that identifies and is screening patients for certain needs, will help improve the patient experience. You also have to take a look at your own total cost equation. So what's your overhead cost, and how does that fit into you're managing your total cost of care? What we've done this year is actually renegotiate our vendor relationships to put service level agreements to ensure that our DME supplies will be in the home at the time that we need them, or that we have them at the time that we need them. So not just the supplies we need for the nursing care, but all the physical and rehab stuff that will have to be in the home in order for us to start care will be there. And without having the service level agreements, there's no guarantee that we can actually begin care when care needs to begin. And I think operationally, it's important for all of us to recognize that this is a cultural transformation within our organization, and setting the priorities will require us to sort of centralize some of these functions like project management, and really figuring out what are the project priorities that we have to focus on as a company. Obviously, within the financial domain, you have to look at how you're contracting. And if your organization today isn't participating in an episodic bundle, isn't participating as a partner in an episodic bundle, or hasn't been part of one of the VBP states, then it's important to start to understand how VBP will actually be the reimbursement structure in future models. These episodic payment models for home care, other than CMS, and now with managed care, will become the framework for which we can get paid for a different service set. And we can then engage things like remote patient monitoring, which will lower total cost of care by bringing in a different discipline, but will actually be able to be paid for on an episodic basis. And then obviously there's things within our revenue cycle that we've spent a lot of time on ensuring that we can interact with health plans and our payers differently to ensure that as we move to these value-based models, they actually are getting the money that we deserve out of that through incentives, through quality, and also through the direct contracting. If you're going to get into value-based payment models, you're going to have to consider whether or not you have to get into reserving. So if you get into a risk-based arrangement, you've got to reserve for those risks, ensure that your organization has some stability around that. And you're going to have to be able to produce some reconciliation data to prove your own value in that value equation as well. So setting those budgets and target setting around predictive costs and what the upside and downside could potentially be will only help protect your organization as you move to value. And I think we've spent a lot of time this morning and yesterday, even last night, talking about the value as a cultural shift within that IT domain, and the fact that data intake, normalization, and standardization is a very difficult challenge. And if you're not operating your own system, we need to be able to purchase that data and understand how we do patient attribution and align our activities to that patient attribution, so that those people whom we are partnering with that are in these value-based arrangements can understand the value that we're delivering. It also applies to the identification and stratification then of the high-risk members. So we spend a lot of time in our organization identifying from the low, rising, and high-risk members to determine who are the most appropriate patients to fall into those clinical pathways to create the interventions that we need to prevent things like rehospitalizations. And obviously that means that you've got predictive analytics that tell who those patients are. You've got workflow tools to identify what are the activities that you need to engage those patients, and you've got dashboards to produce results. The big thing that we've been able to do over the last year is show back to health plans, this is what has happened to your patient population. This is how we've managed utilization, and this is how we've managed readmissions, and this is how we've improved quality. And we've also then be able to turn that back and face it towards our own staff. So again, going back to that leadership domain, we've been able to teach our staff about the significance of quality, the significance of patient experience, and the significance of the financial domain that we're managing through these dashboards. Obviously, there's things within the IT and analytics that we have to be conscientious of, and that is that data exchange with external entities and be able to share our data with others in a way that we haven't before, and the data security and privacy rules. I think it's important to evaluate who the ACOs, IPAs, health plans that you're partnering with, understand their side of the risk equation, what's important to them. Are they participating in just some quality incentives? Are they participating in full upside, downside risk, or is it just upside? And if you understand where their needs are, you'll understand how you can approach them and how you can engage them differently. We're doing a lot of work right now with, as I said, with our DME providers and HIT providers, but also with subacutes to determine how the subacutes, obviously, if anybody's familiar with what Kindred has done over the last year, one of the largest home care agencies in the country, has divested itself a lot of its brick and mortar, thinking that that's potentially not the future of home care or the future of value for them. Instead, they're focusing on divesting those brick and mortars and then reinvesting in partnerships with those people who will actually be good partners in managing a total post-acute management. I think we also have to start considering ourselves beyond total post-acute. We have to say, listen, as we align our business interests, subacute providers become, I don't want to say less important because it's an important industry, but managing patients within the community is important. We get almost a third of our referrals from community-based referrals to keep people out of the hospitals, to keep people out of subacutes. But what we're doing is designing programs where we bring the patient back to a subacute facility instead of the hospital if the patient doesn't meet a hospital need. And what that allows us to do then is actually create a better partnership with those subacute providers. And then we're going to have to, one of the reasons why we have a fortunate position in our marketplace is size and scale. I think as you look around your organization, you look around your competitive landscape, one of the things that makes us relevant is our size and scale. And if you don't have size and scale, partnering or acquiring with other like agencies who used to be your competitors may need to be an option on the table for you guys in order to actually bring that value equation back to those risk-bearing entities. I'm going to take a different approach. I think, a couple of times it's been said last night and this morning that really the patient is first, but when you're considering this shift to value, the patient is part of the equation, but you have to put the hat on of the partners that you're partnering with and what's in it for everyone. Everybody has a different interest. And that pie of which we manage within the healthcare spend, which home care only represents 3%, isn't the objective here isn't to make that pie bigger or to make any slice of that pie necessarily bigger. It's to shrink it or to stabilize it. And so we have to think about all of our interests within that pie, and we have to share that interest across the domains and figure out the new business model in which we will operate. Again, we have to build that infrastructure to support the value equation, and we have to execute our strategy by creating that culture of value. It's not just a strategy because culture eats strategy for lunch. So we have to create a culture of value throughout our organization. I think that's it. Questions? I think we have a mic too. Got 4 minutes.
Well, I'll raise a question. All right. Since I know you, I'm from New York too. Okay. So, one of the things, and that was great. On behalf of ACH, all proud of that kind of presentation. And one of the things that's obviously a factor that you have to overcome is the regulatory structure. In home care, if anything, the regulatory structure is going the other way with new layers of COPs and other kinds of things, really going the other way for where a lot of these partnerships need to be. And can you just talk a little bit about strategies that you implement to try to work through that structure, cut around it, or create efficiency so that you still are attractive to partners, particularly like physician partners and others in the system?
Yeah, and one of the things that we're working on right now is exactly that. So within the domain of home care, the provision of home care services itself, we are very restricted to provide independent services that an ACO or a health plan might otherwise do, right? And so we're trying to actually partner with them on, we have the resource availability, and under a different context, is there a way that we can use our resources within your model as a staff model, not within the certified agency, right, but outside of that certified agency to provide different levels of services. One of the things that Marki mentioned was patient escort. So can we provide a home health aide to a hospital discharging a patient for that aide to go home with that patient on day 0 when they're most at risk? Before the certified episode starts, can we provide an aide to that hospital and have the hospital pay for it? And then support that patient until the certified agency. And those types of arrangements allow us to be more flexible and allow the ACOs or the hospital organizations to work with us differently, and it sort of sits outside the domain of the certified event, but is an extension of the agency itself. People are ready for the sign.
They want the sun.